Yeah, sure. Thank you, Nitish, and thank you everyone for joining. And my name is Jit Mangwani, one of the consultants in Leicester. Really appreciate people joining in on this festive season as well as football season. So people who've made time to come and join us, thank you very much. So for the next hour or so in this webinar, we're going to be essentially looking at foot and ankle cases. I've been joined by Lyndon Mason and Mark Davis from Sheffield. And the theme for this particular webinar is that we're going to look at trauma cases, some learning points, and we're going to be keeping it interactive. I think this time of the evening, certainly my brain stops to work most of the times. So keeping it interactive amongst ourselves as well as with you all. So please put your questions through Q&A if you can, please, rather than chat. We will try our best to answer through Q&A or through discussions. I also have to thank OS, Auto Solutions, for supporting this webinar, who've been really good and generous. So thank you very much. So what I'm going to do next is share the screen when I figure it out to get Mark started with Liz Frank injury case. So just bear with me a second, please. Can everybody see the screen yet? Just give me a second. So 1 second and I'll turn it again. The only thing is I can't see the PowerPoint now.
Do you want me to share from my side, Jed?
Yeah, you can do. The only thing is I've got Mark's case here. Just 1 second.
I've got it also.
Can you see the screen?
You can see it now, yeah.
Yeah, perfect. Yeah. Lyndon, is that you sharing or me sharing?
No, I think that's you sharing. Yeah.
Okay, great. Right, so let's get started. Thanks, Mark, and I will hand over. You can just tell me when to move, and I'll move this slide.
Yeah, thank you, Jit, and thank you, Nitesh. Welcome, everyone, from BIOS on a cold Wednesday evening. So I'm going to just introduce you to hopefully a few take-home messages regarding Liz Frank injuries, and perhaps just trying to make you aware of the extent of the trauma that can happen with what is relatively low energy injury. And I'm going to indicate where I'm coming from with this case here, who's a 30-year-old lady who's from Rotherham. And she was out in her high heels and she literally, what we call in Sheffield, cockled on the edge of the pavement. So she twisted her midfoot in her high heels. And straight away, you can see from these plane films that there are multiple things going on in the midfoot. Next slide. So the first thing you can see there is the incongruity of the first TMT joint. Easily overlooked. It's worthwhile looking at that in both AP and oblique and lateral planes. Next slide. You can see that there is a spiral fracture to the shaft of the third metatarsal, perhaps nothing particularly to worry about in its own right. Next slide. And you can see here classic injury to where we would call the Liz Frank complex, where the Liz Frank ligament would attach. There's some comminution there. Next slide. And then subtly, you can see here that there's been some compression of the cuboid. So quite often in these Liz Frank type injuries, there is injury to the lateral column, and that can take the format of many different presentations and types of injury, but in this case it's a cuboid injury. Next slide. So to summarize, so far on these films, we have first TMT joint incongruity, the comminution of the second metatarsal base, quite a lengthy third metatarsal shaft fracture and some crushing of the cuboid. And I could show you a whole lot of CT cuts that basically demonstrate that better, but take it from me that's what we would do as a CT to get more information to plan how we're going to manage this. Next slide. So for me, I'm very keen on what is really a utility dorsal approach for my Liz Frank injuries. So it's along the line of the second ray, particularly if you have to try and access the third TMT joint. You can always access the first TMT joint through an accessory medial incision. And you can see here that I've got the curette under the tendon of extensor hallucis brevis. So the muscle is at the bottom of the picture, the tendon is at the top of the picture being held up by the curette. And you can see underneath the shaft of the curette, the displaced base of the second metatarsal with the comminution. So this exposure is a great way, it's extensile, it will allow you to do your fixation. Next slide. So for me, I use K-wires only really as an intraoperative reduction tool. I don't use them as a primary treatment modality, but you can see straight away that I'm getting amongst the injury and trying to pin it back where it should be so that I get anatomic reduction. Next slide. And an accessory incision here to access the cuboid. So the picture on the left, it doesn't project very well, but essentially it's a bit like a Schatzker injury of the plateau. There's been crushing of the cuboid, and essentially you take the lid off the cuboid lateral wall and elevate the joint surface and then put your lid back down and fix it. And you can see I've temporarily held it with a wire on the right-hand picture. Next slide. And so then what I've done is to go on and treat all of the injuries sequentially. So the Lisfranc complex, I've effectively bridged that. I've reduced the first TMT joint and bridged that. I have elevated the cuboid fracture and restored the column length. Perhaps the only thing that isn't particularly optimal is the plating of the shaft fracture of the third metatarsal, but that was the longest plate that I had in theatre that day. Next slide. So quite a complex injury, but actually I don't think it's particularly atypical of what we see in our practice across this country. So you can see the two classifications that have been projected there, and you'll be familiar with those. Those were written, and in those times, Lisfranc injuries were diagnosed from X-rays only, and they tended therefore only to be picked up in the high violence injuries. And therefore you see what really is a very high violence spread of fractures there. But actually, if you look hard and you have CTs and with better radiography of today, we can see the same type of injuries, perhaps with less comminution in our practice across the UK. Next slide. So those fractures are classically across the whole of the Lisfranc complex, but actually a small proportion of them have a longitudinal component, a bit like the injury that I've just shown you. So the longitudinal component of the case I've shown you was along the lateral column with crushing of the cuboid. But actually, if you have a look at very carefully at combined Lisfranc and Chopart injuries, they're quite common. And you can see the paper on the left is well worth a read. It's Martinez Richter's paper from Foot and Ankle International in 2001. And that basically shows you the proportions of coexisting injuries with other parts of the foot with what was just deemed to be a simple Lisfranc injury. And in Sheffield, we've looked at this in more depth and published in Injury in 2019, where you can see the different exit lines of energy, A, B, C, D, and E, being through joints and through bones along the medial column of the foot. And I think it's well worth just explaining to you and trying to raise the importance of diagnosing these injuries, because if you just focus on the Lisfranc area on its own, you will miss quite a lot of concurrent injury. Next slide. So this is an example of that very thing. So you can see here the usual approach, the dorsal approach along the second ray. You can see on the right-hand photograph the split in the navicular. Yet again, you can see the belly of EHB, which has been lifted up by the forceps. And believe me, right in the bottom there, where that laminar spreader is the torn Lisfranc ligament. So you can see that the energy has traveled all the way along that column. And therefore in image B, you can see where that has been addressed by putting a Lisfranc screw and then fixation across the intercuneiform joint and across the navicular. And actually, you can also pick out, those of you who are more observant, that there is something going on in the lateral column with the cuboid too. Next slide. So I really want to bring to the fore this paper here, which is excellent. And of course, this is going to be recorded and you can go home and then find this paper. But it's really the paper that I pin all of my midfoot reconstructions. And I think that Liz Frank injuries really do come in the manner of midfoot reconstruction. You can see these principles here. So the two columns, the way I divide them, are the lateral column on the left and the medial column on the right. And what the principles say is you should restore the appropriate lateral and medial column length. In other words, try and rebuild them to the way they should be. And you then need to re-establish the relationship between the forefoot and the hindfoot. And that's where your Liz Frank reconstruction in the transverse plane is important. It is really important to preserve talar and navicular joint function, but you may have to temporarily bridge that in order to achieve union with a navicular fracture or a talus fracture. It's also very important because of the mobility at the fourth and fifth TMT joint to preserve that. So if you do bridge plate across that, again, it's fixation that would have to be removed. And the principle here is to use stable fixation to maintain those reductions. So this paper was 2001, and even at that stage, Pinney and St. Georgian were trying very hard to avoid using just K-wire fixation. And the whole premise of this is to allow the soft tissues and the bone to heal with time. Next slide. And this is my final take-home message. And the principles here about adopting Pinney and St. Georgian's recommendations there. CT is mandatory in planning your surgical reconstruction. It's very much an a la carte approach, like the case I explained, where you take on each injury in turn. It's worthwhile bridging and non-bridging, and you can use locking or non-locking plates, external fixation, and limited use of K-wire fixation. So at that point, I'm going to finish.
That's great, Mark. Fantastic, concepts there to share, and as usual, great value in terms of.
I was going to say, while you're getting the next bit up. So, Mark, there hasn't been any Q&A bits come through. Is it okay if I ask you a few questions?
Yes.
Practical ones. So, firstly, if you're going to address, because you showed a 3-column injury, obviously medial, central, and lateral column. Which ones do you address first? Do you address the central column first, or do you address the medial column first? Which one do you address first?
Well, I tend not to use the central column theory at all. I just split them clearly into two. So I think of a stable medial column, and that was the diagram I showed. So I bind that into one and then effectively create a medial column. So essentially what you're asking me, if you are a central column believer, is I do put the central column back onto the medial column and work from there. But actually, yeah. I think is important when you have these longitudinal injuries is actually to work from proximal to distal.
Okay. Yeah, the reason I was asking, because obviously you're I go in the 3 columns when it comes to the Liz Frank, and then 2 columns when I'm further back. But you tend to bring in your second TMTJ first before your first TMTJ if you are just addressing that level at the TMTJs.
Yes, exactly. If you're just at the Liz Frank level, then if you try, the problem with the saddle shape of the first TMT joint is very easy to rotationally malreduce it. And one of the best ways of trying to gain your bearings is to then bring the second base in next to the medial cuneiform. Now, the problem can be is if you have comminution at that level, then you might have to reverse that decision, that maneuver, and go for the first TMT joint restoration first. But in general, that is the easiest way of working out that 4-corner reduction.
And if you are addressing the second and third TMTJ, often I find that the 4th and 5th, if it's part of the same injury and you don't have any cuboid crush or lateral column length loss, it often comes all as one. Do you put any fixation on the lateral side then if you find that the central is okay?
No, very rarely have I done any fixation of the lateral column. Occasionally, if it's really unstable, it's worthwhile making a small incision, and you can use like a juggernaut or a Mitec type anchor, and to effectively refix the capsule onto the cuboid.
Yeah. So when we done a recent review across the 4 obviously large centres doing this, it was all the same as well, Mark. Very few were being K-wired, even though K-wires was the, when I was I'm younger than you two, slightly. But even when I was a boy, everyone was K-wired the lateral columns, and they do not require K-wires. I fully agree with that.
Try and rub that in, Lyndon.
the EHB that you showed, one of the things that I've always I guess used the EHB is to find the neurovascular bundle.
Yeah.
So to medial to the EHB, the neurovascular bundle should be present. Is it? Do you look for the same as well?
I do. The reason why I think it's a good landmark is for the neurovascular bundle, and it tells you you're in roughly the right space for finding your second TMT joint. And it's a bit like the windows of when you're doing acetabular surgery. I just move it in and out and change the windows so that you can get access to the various joints.
Because my practice is slightly different. I tend to use 2 windows if I've got a medial column injury as well. I'll tend to have a mid-medial incision just in my hands. I find it easier to gauge the first TMTJ and to bridge it further up if needs be. We've all got a little bits on me. Sorry, are you?
Yeah, so I was just saying, similar lines. A couple of questions that always come up, particularly from registrars. Say, you've got a middle of the night scenario where you've got a midfoot pretty much dislocated, or a non-specialist foot and ankle, on call for 2 or 3 days, and there's no specialist around to tackle this straight away. So both of you can take in turns. Maybe Lyndon first, because Mark's done a lot of hard work so far. We put him on the spot. So what are your top tips to say, how would you tackle that situation? In big MTCs or trauma units, etc., we don't have that issue because one of us is always around. But there are still district general hospitals where the non-specialist colleagues have to deal with this till we get to the point of then be available for fixation or whatever needs to be done.
So the subtly displaced don't require anything apart from a regular plaster. Yeah. Those which are grossly displaced, I wouldn't want them to attempt an open reduction and a reduction with a medial or lateral or both column X-fix. I'm also not a fan of K-wires sticking out the skin into the places that I would like to then make operations. It queries the pitch, so I'm not a fan of that at all. Sometimes, with the very severe, RTCs type of injuries, we got really, really smashed up injuries with bone loss. Sometimes the X-fix can be on for a while, for a few weeks, sometimes a little bit longer as you allow the soft tissue to settle. And sometimes you put one plate in and then leave an X-fix on the other column, and then come back and do a stage surgery. But yeah, the main tips are leaving a plaster if you can. If you need to reduce it and can reduce it and put in a plaster in theatre, that's fine. Otherwise, put a small span and X-fix on the columns.
Yeah, Mark, anything else to say on that?
I would wholeheartedly agree. I share Lyndon's sentiments about interventions completely. The only thing which is really rare as hen's teeth, which is a real problem, is if you have a dislocated cuneiform, because the way they're shaped, they're wedge shaped, they tend to spit out the top or to the side if it's the medial, and they will rapidly go to skin necrosis and loss, and they're not difficult to reduce with a fixator, but they will tend to keep popping out. And sometimes in order to preserve the skin, it may be reasonable to then pop a wire across one to provide a temporary reduction. But that would be my only caveat.
Yeah, I think if you were to put a wire, one of the other things is we're definitely going to come back and do a definitive fixation. You can cut and bury these wires because, you know, there's no issue with it. We'll be able to find it in a couple of weeks' time and pull it out. So if at all anybody uses wires, don't stick it out of the skin and leave it. Cut and bury inside the skin, basically. But I agree with you both in terms of using X-Fix and leaving the subtle ones without dislocation in a plaster, completely let the soft tissue settle so we can come back another time and fix it. So the other thing is on-table stability. So, you know, some of these that look fine when you look at the radiographs initially, and then you look at the CT and you just think that looks a bit more. And I'm sure you all had those, and I've had those myself. Could you go through your sort of thought process on how you assess stability on table? Maybe Mark this time first, and then we can come to you, Lyndon.
Yeah, I think before you got to the table, I often do weight-bearing x-rays. And if weight-bearing x-rays are equivocal, and you then do an EUA, to do a decent EUA is quite difficult. But I think there's one thing that, and again, it is relevant to my talk, is that one thing you don't do is people don't think about taking the big toe and rotating it as part of the assessment, because if you do that, you can quite clearly see, and if you test the other side, you will see that there was instability of the medial column, and that can happen at the first TMT joint. And that's a very simple test to see whether or not there's something going on. People are always trying to sort of take the foot and move it from side to side and up and down, but actually rotational movement to the foot is almost as useful in terms of part of your EUA.
Yeah, thank you. Lyndon, anything else from?
Yeah, so there's a few bits. Admittedly, there's a lot of live screening involved, where you're moving the foot in all different ways. But if you imagine the sorry to use columns, as you know, I'm a column guy. So the central column ones is that you plant affects the foot and you push up on the second ray. And it's called the push-up test. And the second ray, and if it's unstable, often that's how it become on your lateral X-ray. You can see it higher than the first ray. So I find that quite useful. But otherwise, as well, is holding both the medial, the second toe and the first toe, and spreading them. And sometimes you can see them open up, and that is often quite useful for the intercuneiform instability. So not only the Liz Frank to see the between your medial cuneiform and your intermediate cuneiform, you can see it opening up by spreading the both toes. But a lot of it is on live screening rather than just a single shot. Single shot,
yeah, no, absolutely. I think first TMT instability, certainly in some of those non-weight-bearing radiographs, is underdiagnosed as well. So, you know, when you get on the table, you realize what Mark was saying. When you twist the big toe, you realize that the first TMT is actually unstable. Brilliant. So I think we've done really well in terms of getting a fair bit of discussion going on. For people who are logged in, you can put your questions in the Q&A. Whatever comes to your mind, don't worry about it, just put it in there. And we're going to move on to the next bit. Lyndon's going to share his screen. With
that was me.
That
isn't me. I will share my screen.
I won't share mine, so it should be okay to do it.
There's a quick question while I'm doing that.
Yeah. Just 1 second, I'll pick that up. So when checking the step off on lateral radiographs, what do we compare the second MT base with to say the step off? Okay, so that's a really good question. So I'll read it out again. So essentially, when you're doing the testing and you're looking at the second TMT base, What do we compare the second MT base to say the step off is there?
So is this during the EUA or on the weight bearing
I
X-ray?
think it's looking at the EUA, looking at the question. It hasn't, the person hasn't said anything about it, but I think it'll be EUA.
Yeah, I mean, that's the oblique view, I think, is really helpful, because what you want to look at is the lateral and medial borders of the intermediate cuneiform and the relative position of the second base. And if they're in alignment on both of those views, then you can be reasonably certain that things are stable. It's very difficult on fluoroscopy to get anything medial from a lateral view, in my experience, because just the X-rays don't penetrate and give you much information.
Okay, there's a couple more before we go. Is that okay to take it now? So
Yeah.
when you're testing instability by spreading the two toes or twisting it, would the patient be under an anesthetic or not? I would definitely say yes. I don't know what your takes is.
Yeah, even though our patients are as hard as nails in Sheffield, we do tend to give them an anaesthetic. We're quite kind.
Occasionally or always.
Yeah. But no, I think it has to be done under GA. Yeah.
To get anything meaningful from that, we have to really do it under GA. That's for sure. The only thing will be, we touched upon a little bit in terms of weight bearing X-rays. I think the subtle ones, certainly I would get them weight bearing about 10 days or so down the line, not immediately, because patients are still sore. So I weight bear them, and I weight bear and compare with the other foot, but I don't compare it on the same film either. So I think those are things to really get it right, because you could easily be fooled. And if you're comparing it on the same film, the parallax doesn't allow for the right sort of parameters to be done. So it's better to ask them to be weight bearing on that leg and have one X-ray for that and compare it with the other. And you can compare obviously on the packs. All right, so we got one more. No, on lateral X-ray, it is difficult to see the intermediate cuneiform if aligned and taken through lateral X-ray. That is true, but I think obviously these are subtle instabilities, and if we're doing it on table, you're pretty much sort of feeling as well as doing it so that you see that subtle movement. You're not going to see a completely dislocated second TNT. Have you got anything else, either of you?
Yes, so you can on your true lateral, you will see your medial cuneiform in place and your first ray, and your second ray will be in line with it. If you push up on unstable, it does come above it. The push-up test has been published. It was presented in BOFAS probably about 4 years ago, and then it's been published since, not by me, by someone else. It does need to be there needs to be a reasonable amount of instability for it to be positive in truth.
Brilliant. Right, so that sets the stage up nicely for some more cases. So Lyndon, over to you.
I'm assuming, Jit, that we're going on to the posterior mal. Is that
go
correct?
for the posterior mal for now, and we can see if there's anything else or any other interest from the audience. We can always mix and match.
So trying to keep this to case-based rather than discussion. Let me close the Q&A for a second so I can see myself. And not going through a draconian lecture. The first one I'm just going to start with is this, which for me is a PATFL avulsion. Would anyone fix this? I'll go to our own panel first.
Have you got anything else on there?
This is all I'm giving you, Jed.
I wouldn't necessarily. Well, I would like to see everything else in terms of what the stability of the ankle joint is, and obviously the patient factors and everything else. But I'm not a big fan of fixing a small avulsion fracture at the back, unless this is contributing to the syndesmosis stability, and unless the injury pattern demands it. I might be saying something controversial here. Mark,
Yeah,
you're on.
no, not at all. So you know, this I think anyone would be when they write to fix this from the back or to fix this indirectly with a syndesmotic screw. I just wanted to show a PHFL avulsion such as this. It was an unstable injury, so a weight bearing view showed it unstable, so that there was a deltoid injury with it as well. So for these ones, like, sort of depending on sort of your, you know, how we'd like to treat it, it's the way that I treat these is with a syndesmotic fixation, be it with a flexible such as a tightrope or a screw based. And that this one's the same. I won't go into that one. So a type 2A, so one's a little bit bigger. So this is your initial view. Weight bearing doesn't look that bad on your AP, but certainly on your lateral, you can see it just moving posteriorly. So this to me is an unstable injury, even though your AP is actually intact. Is there anyone here who wouldn't CT this?
I would definitely CT this. I'm sure Mark's going to agree. He's nodding, but you're on mute, Mark.
Sorry, yeah, no, CT
Yeah.
definitely.
Most definitely CT this one.
So this has become quite common now across the country. It's when I try to introduce to our own centre to CT every posterior malleolar fracture, it came with much disdain and unhappiness, although it's now commonplace within our practice. And the little small fragment that people talk about can be quite a large fragment because the posteromedial side you cannot see on your X-ray. So this one did undergo a CT scan. You can see the fracture fragment there, and you can see on the one on the left how the talus rotates posteriorly into that hole. So you can see that that is not sitting properly. So how would people approach this? So it's a straightforward fibula, distal fibula fracture, a posterior malleolar fracture, a reasonable size.
I'm trying to see if there's anybody from the floor interacting. I'm desperately trying to see if there's any Q&A coming through, but I can't see any at the moment. So in my hands, this will be a posterolateral fixation.
Yeah, I would agree. I would agree.
So it's quite strange because my practice has gone away almost exclusively away from posterolateral incisions. But I think a lot of it is due to the fact I just don't see these type of fractures anymore. The kind of fractures I'm seeing are much worse than this at the moment. I don't know why. But this was the type of thing I was seeing a few years ago before COVID. But they seem to be a lot worse nowadays for me. So yeah, you're right, Liz. So, well, for me, this was fixed through a posterolateral incision. We can discuss whether or not one screw, two screws, a small plate. Should
we discuss that now? Because I think there's a lot of, particularly with trainees and you know, people who are doing this but not as frequently as maybe you and I and Mark are doing it. What is the optimum fixation? You know,
so
what would you say, Lyndon?
Yeah. So first of all, this is not my normal practice. I usually have at least two screws. This is my case, but I usually have two screws. The reason for that is a rotational injury, and it would often rotate on this one screw. The other thing is that if you place in the screw, this line here, you can see the cursor, I assume. Yeah. This line here is the posterior incisura, and this is your anterior aspect of your tibia. So any screw lateral to this area here will be in the incisura. So it's actually medial to that, so it's in a good place. In regards to putting a little plate on, I often would put a little plate on to prevent, when you get this compression, the fragment rising up, because often it can be up like a little hill. So when you get compression, you lose on the last bit of compression and it elevates. There's quite a few papers out to show that it's biomechanically more stable, being, does it really need to be biomechanically more stable, because it's likely to heal in that position anyway. So for me, I would often put a little buttress plate and a compression screw is my most common construct, be it it's not on this one.
Mark, any thoughts on that?
I quite like this technique that you've got here. When the fragment's small enough, you can generally control the rotation with 2K wires and use one of them for your lag screw fixation. And then once the plate...
Yeah, I've lost Mark. I don't know. Can you hear him?
I'm unsure. There's a question from Ashok Singh.
Yeah. So
does restoration of the fibula length not impede if imp?
I think it's not important if you're fixing posterior mal. So it's restoration of fibula length not important if we have fixed the posterior mal. I think it's very, very important. That's what I'm deciphering from it. I don't know.
So when you bring the postural mal to the right length, often if it's an acute fracture and you've got to it relatively early, you can often get most of the fibula length out at that time. Similarly, if you're fixing the fibula, you can often get the postural mal out to length at the same time. But it's I think that's answered that one.
Yeah.
So the take-home point of this one is that it's a simple fracture, and the go-to approach is usually a posterolateral incision. Mark?
Yeah, so it's a good question asked, because this is a supination external rotation injury. And if it was a pronation external rotation injury, the fracture line on the fibula would be much higher. To dissect and get that fibula out to length can be quite onerous, and it's not an easy dissection. And if after having restored the back of the ankle, you can see that you've got the fibula out to length and almost reduction of the fibula, then you can leave those alone.
Yeah. So whilst we're there, in terms of the fixation, we said, okay, fine, a screw, or do you really have to use compression screw, i.e. bar threaded screw through the posterior mal fragment?
So as an articular injury, I would generally use something in a compression mode. However, if you've got a die punch fragment and you've lost a bit of articular surface, you can over compress. I've done that myself. Sometimes then you require a more of a raft type screw. So through a locking plate, for example, can keep a die punch down in the right position. I got some of them cases coming up now. Yeah,
no, absolutely. Just one more thing, and in terms of the timing of these fractures, when we get in with what goes on with hip fractures and other fragility fractures and everything else in the trauma units, sometimes you're 2.5, 3 weeks down the line and everything is kind of half stuck down. Any top tips to get the posterior mal reduction right, as well as fibula out to length?
So first of all, I would open both at the same time. So rather than just open the postural mal and then trying to fix that before going to the fibula.
Yeah. I
would often make a medial postural medial incision, and we can go through that now. Especially if the fragment comes anywhere near the tibialis posterior sheath, because then you are hitting it in line with the fracture. So if you try to go from top to bottom with a fracture that's almost united and try to peel it off, it often fragments. But if you come in across the joint line from the medial postural medial incision, i.e. across the back of the tibia, it's much easier to open the book of the fracture. So one of my top tips, and unfortunately, Jit, is becoming a lot more common practice, having fractures much later down the line. And that also may be with the fact that I'm doing the medial postural medial a lot more than the posterolateral nowadays. But yeah, you can come across the back of the tibia much easier with that. Yeah, and the other thing, if I may add, is if you got the situation with 2.5, 3 weeks down the line and it's all slightly stuck down, you can actually use the distractor on the fibula quite easily.
which helps you. So like a 2-pin distractor, like we use it in foot and ankle a lot, interment type distractor. And a lot of trauma systems now have got that distraction device. Essentially put 1 pin proximal and 1 distal on the fibula and gradually distract it out, and it will fall back in place and also allow your posterior mal to come down. I don't know whether you guys do it. I do it. Most of my fractures are now 2.5 weeks down the line.
Yes, no, I agree. Often you have to get your fibular length before you can achieve your postural mal. So it's the other way around than what you usually do with a fresh fracture, where the postural mal will often come down and bring the fibula. You often have to attack and get your fibular length before you can get the postural mal in the right position. So it's often the other way around. There's a
question. Yeah, have you read it?
So there's the question is, when can we say that we don't need to fix the posterior mal and ligamentous would help the dorsiflex foot? So it's a great question, and it's been answered a little bit in the literature so far. We know that, you know, the old-fashioned that if it's greater than 30%, you fixed it, and if it was less than 30%, you didn't. We know that's definitely incorrect nowadays. Morphology of the fracture definitely determines the functional outcome. And we've been fixing a lot more of these rotational type pilons. So those that are like the first case I showed, the PATFL avulsion, they will often come back in the right position and you get the syndesmotic correct. But often you still do need to fix the postural mal to get that rotational pilon. And a lot of it is based on the way the syndesmosis works. So the fact that the syndesmosis pivots on your postural mal. So biomechanically, even the small fragments can cause significant problems because it doesn't have that pivot. So you can't sit back and pivot to rotate the fibula out. So often we get much better results by fixing these, what were smaller fragments that weren't fixed previously.
Great, thanks very much. So let's move on.
Yeah. So how much time do I have before?
Well, I think we can go through another case or two, and then we will have some summarizing points.
Okay. So I've talked about the safe zone. So that if I just move through to the next one. So this one's with the die punch fragment. So die punches have become a lot more has been a lot more relevant in the last 2 years, where the die punches have certainly been either put in the bin or ignored, especially if you come through the posterolateral incision. So this is the case that we have, and you can see already we have a large posteromalleolar fracture, we have a comminuted fibula, and we have this die punch already on your x-rays. Now, I think most people would agree to get a CT scan, and this is the CT recon showing this fragment here. We have a small little avulsion fracture from the intermalleolar ligament, comminuted fibula, and you can see your die punch here. How would people approach this one?
Mark, do you want to take that one?
So this looks to me like the typical elderly case that comes through now, because the other thing you can see on the left-hand screen is the comminution around the Wagstaff area. So this is not an easy fracture because of the degree of comminution. So this is definitely one where you have to get all of the mobility from mobilizing the fracture fragments, recreating the maximal point of deformation at the time of injury, and usually that with rotational manipulation of the ankle and with a laminar spreader or a dental hook on the posterior mal and on the fibular fracture, you can get to the die punch and either push it down or remove it. And this, for me, this just looks typically elderly. And if it's elderly, I tend to remove them and then crack on and do the fixation once it's removed. There are a huge set of issues with this one in terms of fixation, because you'd also want to be thinking about how to restore the fibular integrity anteriorly.
So unfortunately, she was 34, and this
Really?
is the bad bone we get in Liverpool.
Yeah.
And this is the kind of the the bone that we're seeing at the moment. As I said on the last case, I just don't see the type of cases that I just showed you. This kind of cases I get now. The one thing I would fully agree with, you can see how comminuted this fibula is. And if you're going to go from the back from this so this is a world of pain trying to get this length, because you'll tend to flex it forward, especially with a straight plate that we use on the posterior aspect of the fibula. And similarly, to get the die punch, you can bring this out on the right through the posterolateral, but it's difficult to do so, and it takes quite a lot of dissection. So actually, I often, as I said earlier, I'm doing this medial posteromedial incision around here now to get into this and open the book like I do for pilon. This is my workhorse approach for pilons and for the comminuted postural mals nowadays. So it's in between your tibialis posterior, so it's a centimeter behind the medial malleolus, in between your tibialis posterior and your FDL, or you can sneak in front of the tib post. I tend to go in between, and you can open this and get to this point here. This one, as we said, it was a young patient, so this one was retrieved and brought down into as good a position as I could manage. And as we said earlier, we're looking at more of a raft type with a plate rather than compression screws, because you don't want to over compress this.
So Lyndon, this is a question for you technically. How do you keep that fragment where you want it, having opened everything up? You've got it reduced. Do you use a simple metal wire and cut it flush, or do you use a resorbable K wire to temporarily hold it, and then you close your book over the top? How do you actually keep that where you see that you've reduced it, and you know that it's going to stay there when you close the book on it?
Yeah, so I usually use a K-wire off plane. So obviously if I'm coming in the back, I'll have to close the book, so I can't put a K-wire straight where I'm seeing it. So we'll come in from the medial side above that fragment. You can often see it coming through. You can often see it just where the fragment is to keep in the right position. But being that, it's often, these small fragments are quite difficult. If it's already healed an element, I'll try and bring it down with more bone. So as in go into the metaphysis to bring it down, rather than just get it above the fracture fragment itself. So you've got a bit more bone to play with. And that's what I did with this case. But don't get me wrong, they're difficult cases. Another thing to note on this, we've seen a lot at the moment where people are saying, okay, just fix the postural mal and then the syndesmosis is okay. You can see on this case here, we've got these Wagstaff type fragments, but also a T-low type fragment off. So this is a 3 ligament injury of its syndesmosis. So just fixing the postural mal is often not going to be enough for the syndesmotic injury.
Lyndon, just in terms of metal work from the posteromedial side, most people worry about putting a plate because it's too close to the tip post, and what's going to happen to it. And there are some published papers now in the literature describing FDL tip post irritation from this metalwork. What are your top tips on that? So
often if your metalwork is on the posterolateral fragment or a large type 3 fragment, it's nowhere near the tib post. It's much more lateral than the tib post is.
It's more for the posteromedial ones.
Yeah, the problem with the posteromedial is then you need to try and get your metalwork so it's out of play. Now there's some newer plates that are trying to correct that, but some of the other plates on the market do come straight down the tib post sheath with the way that they're supposed to be applied. But yeah, you need to try and stay out of it as much as possible. I've had one case where there was a large medial pilon, and the medial pilon was then I treated it with a large plate. It was a shaft fracture as well. And even though I was nowhere near the tib post sheath, I did get tib post sheath stenosis. So when I'd gone back in to take the metalwork out, the tib post above the sheath I saw was very, very hypertrophic and was not passing through the tunnel. So you can get some stenosis, but I've only seen it once.
Thank you. We got a couple of questions in Q&A. So first one is from Sanka. And it's a really good question whether when you have a large posterior malleol and unstable trimal with substantial blisters and soft tissue injury medially and anteriorly, is it okay to go at the back and fix the posterior malleol and put an X-fix and come back and do medial side later, etc.?
I personally never have. I've usually, like, so with an X-fix on, it is controllable. I've never really found any in my practice that I've not been able to control. You can't get them perfect, don't get me wrong, but you can usually get the ankle sitting in the mortise. So I've never had to do it myself. I'm unsure if either of you have done it.
I think in the situation that Sankar is alluding to, the great thing about the posterolateral approach is I can't prove this, and I've been wanting to study it for ages, but it doesn't blister as much as anywhere else around the ankle.
Yeah.
So it's usually your kindest route in. And if you've got a very large posterior malleolar fragment, you can usually really robustly fix that. And you wouldn't even need to do an X-fix. But if you did, or if you even just did the posterolateral approach, you could always come back at a later date to do the medial malleolus. That's not a problem.
Yeah, I haven't had to do either, but I think, as you say, Mark, this is obviously observation that you don't have blisters around that. Yes, there's extensive soft tissue injury to the envelope all around when something like that happens. So we can't discount that if there are no blisters, there's no soft tissue injury. But the blistering obviously happens anteriorly and medially, and much less on the posterolateral side. So when you go in, sometimes you have like a week, 10 days down the line, you're going in, and the medial side is where you've got the blister. But most of your fixation can be achieved from a posterolateral side easily. And you have a tiny fragment on the medial side that you're not worried about too much, or have to come back and do it another time. But I think by and large, if you're putting an X-fix on, you will be able to hold that foot in roughly in the right place with the ankle roughly in the right place in the mortise, and won't have to do anything major.
Because practically it can be quite difficult if you're going to do a posterior incision and then have to put an X-fix on, because you will generally have to turn the patient, even with a quad frame, you generally have to turn the patient back into the supine position to put the frame on. Is another question, what would be a sequence of fixation in this fracture pattern? How will you position the patient if the hip is very stiff? So my sequence is generally in this one to open the book, if it's an acute fracture, so if it's not 2-3 weeks down the line, is to open the book, get the posterior malleol in the right position. Then that often gives your fibula length, and then you will then attack the fibula to get length. I will put you can see the middle picture of a KY in the medial malleol to stop rotation. That can often be quite helpful to get your rotation. In regards to position, if you don't mind, I'll go back. I acknowledge, and I think, Jit, you need to do some your cases now.
No, we're good. I think we're having a good discussion. So I've just put up cases for all of us to share. So it's not a problem.
Okay.
There's another good question from Ashok Singh. So he's basically saying, do you want me to read it out?
Yeah, go.
Yeah, I'm just getting to the setup.
Okay. So do you want to carry on, Lyndon?
Okay, so there's two setups. This is the way I used to do it routinely, which was a prone position, Montreal mattress, and this is the operative leg, and the other leg is dropped out the way. So the tables I use has a movable legs where the legs can drop. So that was the prone position I did most of the time, but now I've moved almost exclusively to the recovery position, where the patient's other leg is up out of the way. The foot is in the prone position, but the patient tends to be in this lateral position with some side supports. This one, you can actually rotate the medial side, so you can get the medial side really easily. A little bit more difficult to get the anterior aspect of your fibula if you're doing a lateral approach, but you can get the medial side very easily, and your leg can just be folded up out the way. But this is primarily the way that I do it now. So, Mark, you were asking the question.
So, Ashok said, I basically coming back to that case that where we talked about, I thought it was an old lady, and you said it was a 30-year-old from Liverpool. He's basically said that with the posterior malleolus and a Wagstaff, he's basically questioning whether just simply fixing the posterior malleolus alone is sufficient because of the triligamentous injury. And of course, so I think we would all be in agreement that it's insufficient. So you have to fix the posterior elements, but you have to have some control of one of the other two aspects of the syndesmosis, so either the interosseous component with a syndesmotic screw or restoration of the Wagstaff fragments by actual open reduction and internal fixation, even if that's the case of just putting in a wire and cutting it flush. But yes, I think it's important in cases like the one that Lyndon showed that the Wagstaff fragment is addressed as well somehow.
Yeah. So I've got two cases that I could show, but I don't think we have time for exactly that. With it's been addressed posteriorly, but you haven't addressed anteriorly. The other thing you asked about the cotton test. Now, the cotton test diagnoses a triligamentous injury, but you won't diagnose your anterior aspect. So often when you fix the posterior aspect, it will still be rotationally unstable. So if you live screen it, it'll externally rotate. You have this widening of the anterior aspect. But theoretically, a cotton test, which is you're pulling on it, your coronal stability might be intact or relatively intact because you fixed one of the ligaments. But that doesn't mean the syndesmosis is fixed. There was a biomechanical paper this year that showed that high fibula fractures generally will require further fixation other than the postural mal.
Yeah, great. Well, thank you very much. And I think there was a comment from Pal Ramesh about implants or Ecumet. We don't know. I mean, I think I don't have Ecumet on the shelf, but there are a variety of implants available from different companies for posterior malfixation or ankle fracture fixation, specific ones. The last one, we got another question. Do you always put the distal screw when fixing posterior mal, as you just have to buttress it? That's from Sajid Athar.
So it's a rotational injury. So it's not like a volar Barton injury in the wrist, for example, where you have an axial load. Often it's a rotational injury. And because it's a rotational injury, if you just put the buttress on, the fracture can still rotate underneath it. So I've got 4 cases that referred into our centre, which had been done, and all of which had failed. I'm not saying all of them would fail, but I got 4 cases which failed because it was perfectly fixed, perfect reduction on table, but then it rotated underneath a buttress plate. So often you will require at least one screw within the fracture to prevent the rotation of the fragment underneath the plate.
Yeah. Great. Well, that's great. Fantastic discussion. And I think we pretty much in time for finishing this webinar with the last couple of things for me to say. Should we just go through, Linda, do you want to summarize some of your posterior mal take-home messages in just a minute or so? And I can then...
So yeah, so my take-home messages for postural mal is, number one, and so if almost all of them exclusively need a CT scan. And so there's 9 papers showing that you completely underestimate or guesstimate the positive predictive value is around about 17% if you don't use a CT scan. Approaches wise, it's if you are embarking on fixing them, then often you need a direct approach, so one that will see the postural mal. And if you do need a direct approach, being familiar with not just the posterolateral, but also some of the other incisions around the back of the ankle, as you may require them. Yeah, I think that is the main points.
That's amazing. Thank you both for really good conversations and top tips and sharing knowledge around these common injuries. So I can't thank you enough. Thanks to BIOS for giving us the platform to come online and chat about these cases and problems that we encounter in trauma cases. And a big thanks to Author Solutions to really sponsor this particular webinar and a series of webinars. So I can't thank them enough for supporting this activity. Have a lovely, lovely Christmas and enjoy yourself and have a happy new year. So see you next year. Thanks, everyone. Bye-bye now.
Cheers.
Feedback.
Thanks a lot, everybody.
One thing, sorry, one thing I forgot to say is don't forget the feedback, please. So please do your feedback.
Cheers. Thanks a lot. These recordings will be available on our website in a few days' time once I've edited them through. But thanks a lot for the faculty, Jeet for organizing it, and Lyndon and Miss and Mark pitching in. And have a Merry Christmas and a Happy New Year.
Thanks, everyone.
Good night, one and all.